As Sue said, my name is Jill Darlington. I work with One Midwives. I've been with One Midwives for 4 years now. I'm very proud to be there and helping the business grow. But you have come here to hear about complex care in caseloading. Hopefully this is going to work, folks. There we go. So why does maternity care need complex care planning? I'm pretty sure everyone in this room could hold their hand up and give an answer to that. Better births, it's highlighted throughout that these group of women with complexities still need better care. They need more informed choice. They need more time to make decisions. They don't need things to be pushed on them and rushed on them. They need to have that space to be able to do it. Personalised care is centred around the woman and the family. We've known this for years, but we are losing grip of it when it comes to women with complex needs. They need genuine choice with unbiased information to allow them to make that decision. Continuity of carer couldn't be a bigger or a hotter topic right now. I'm sure many of the trusts and the universities you're with are looking at how to implement this in many different ways, and complex care needs to be involved within that. We have found over the many years we've been in practice, actually continuity of carer hits biggest for those women with complex needs. They need that support more than what's generalising here, a low-risk pregnant woman, okay? Safer care. We need safer care. Complex care. There are a lot of risks, but people view risks in different ways, okay? Professionals need to work together. So that is not just midwives from different areas. It includes your anaesthetists, it includes your consultants, your registrars. It includes absolutely everybody in that sort of diorama of maternity care. Leadership for a safety culture is key. You have to be able to be honest, and you have to be able to hold your hands up when things haven't gone the right way. If people aren't honest, we're not going to learn. Although this is built into your serious incidents and your root cause analysis, it is done different everywhere, okay? And the increase in complexities. I can't remember what was in the news the other week, but a 66-year-old woman or something like that gave birth. That is totally different to a low-risk woman giving birth at the age of 22. You know, there are an awful lot more things in there. People getting pregnant at a later age is a big issue at the moment, okay? And it needs to be addressed as we get older. We get, unfortunately, an awful lot more complexities in our medical care. Choice, huge, absolutely huge. Women have choice. Families have choice. We've all got the personalised maternity care budgets now, okay? So that is working towards women being able to choose where, how and where they access their care. That is going to become more and more complicated. We need to be able to work on a cross-boundary basis between providers. So why can't they actually have their antenatal care at one trust but then choose to birth at a totally different trust? And that, from sort of a higher level as a provider to provider payment, needs sorting out. We can't let that just go on and on. Women should still be getting this care regardless of whether they choose and who they choose to provide that care. Okay, so one-to-one statistics, bit of a background. We've been around since 2010, but it was very small then, started as a pilot by three or four midwives to improve outcomes in the Wirral area of Cheshire and Merseyside. So they needed to increase the breastfeeding rate, decrease preterm rates, increase engagement with maternity services, and I can't remember what the other one was, but anyway, they smashed it, basically, through continuity of care in these midwives. At that point, they didn't have intrapartum insurance. It was just for antenatal and postnatal. They still smashed those outcomes, all right? We have grown significantly over there. This is a snapshot that we took from last year. We've certainly grown a lot bigger since then, so the number has certainly gone up. We do have a cracking home birth rate. That is a choice that we offer to all our women, including those with complex care issues. Our normal birth rate for women who start their journey with us is 93%, with an emergency caesarean section rate of 3%. That's not bad going, just based on a continuity of care model. Our continuity of care throughout the whole process is 93%, and our breastfeeding initiation rate is 98%. And actually, our in breastfeeding at 10 to 14 days, where it's measured nationally, is not far below that either as well. Okay, I'm getting a dry mouth, bear with me. So we like to celebrate our success. It's really, really important for the midwives who are doing the work out there in the community all the time. So we put together stats, these are from last year actually, But you can read them for yourself. In April, 22% of those who had a home birth were considered what we call high risk with complex needs. 39% in May were considered high risk. Some of those risks very different. So I'm just going to read a few out. We had a grand multip. We had a mother with epilepsy. Ones who included previous PPHs, previous retained placentas, maternal age over 40, gestational diabetes, low platelets, codeine use, VBACs, and the highest BMI we had was a BMI of 52. Okay, all delivered at home, all delivered safely, all with individualised care plans. Perceptions of risk differ between every single one of us in this room. Okay, so perceptions of risk to a woman and her family and her partner is also very different. If you can imagine the scale of it from a perception of risk to someone who only ever sees the abnormal to a woman who has been living with epilepsy all her life, it's very, 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 very different. We've got to be able to embrace it and be that middle person to be able to balance that risk for them. Okay, and this is how we do it within Caseloading Care at one-to-one. We have a baseline document called MMR, Midwives and Mitigating Risk. And yes, at first, when we were all introduced to it, we all thought we were getting another vaccination. We soon learned we weren't. It is a baseline document based on the red, green, amber scaling of risk for many, many organisations now, not just in NHS. I think originally the healthcare possibly pinched it from the airline industry. I don't know. It's a model where a woman could quite happily come into the caseloading model of care and be green, low risk. But we don't know what's going to happen in that pregnancy. So she may jump straight to red for some reason, but actually by the time she gets towards delivery, or birth, sorry, she'll be back down in green. It depends how those risks are mitigated throughout. Risk can't be ignored. We can't do that. It's just going to be in our face, and it can't be avoided. So we've got to be able to meet it head on, and we've got to be able to meet it head on with confidence by increasing our knowledge. Every student in this room, every midwife in this room, every AMP has this knowledge. Sometimes we do just forget about it. We can't expect to have it at the front of our brains all the time. Birth is normal. It should not be pushed towards the medicalised, but we can't ignore the fact that some things do need to have a medical element to it. But it is a life event for that woman. It is huge. It is empowering. It is life-changing. And she needs to be respected in that fact and to have her decisions validated by us. Okay, so one of our main things that we do within one-to-one to encompass, hopefully, everything I've just talked about, is what we have, a care bundle, okay? So the care bundle, as an idea, is not new to any of us. The Saving Babies' Lives is a care bundle, okay, to sort of take in all those risks. Our care bundles focus on specific things, okay? So we provide an infographic. This infographic is an interactive infographic for the woman. It generally tells her about continuity, known care in labour and things like that. It highlights some of the points, the main facts. Sometimes it's our statistics, sometimes it's national statistics, sometimes it's a bit of a plan. But in every care bundle at the bottom, we have an interactive link to the research that backs up what we've decided. Okay, so it takes you to NICE guidance, it takes you to the Royal College of Obstetricians, it takes you to the birthplace study, it takes you to Sarah Wickham, it takes you to Spinning Babies, it takes you to support groups. And those can be national support groups, individual ones, or just Facebook forums, okay? We have to embrace social media because that is where a lot of women get their information and their support. We can't ignore the fact that that is having an influence on people's decisions these days. So we're going to be open, we're going to be honest, we're not going to hide anything from these women. We're not going to say, well, this is what we do. We're going to say, actually, take a look at it all and then you decide, okay? The information sheet is a bit more wordy. It can contain diagrams, it contains all the choices, okay? So in every single one, there will be a choice for birthing at home, there'll be a choice of birthing in an MLU, there'll be a choice for birthing in an obstetric unit, and there'll be a choice of an elective caesarean section. Okay, with the recommendations for it and how to access that care. Following those care bundles, they come as a package. If we need to, and the risk has not been mitigated by the time we're coming up to term and ready to birth, we're going to create an individualised plan of care, okay? And that I will show you examples of the other two, but unfortunately I can't show you examples with that. It's a little bit of confidentiality. But it is based on the care bundles, and if we haven't got a care bundle for that particular topic, then the midwife will go away and she will look at what the risks are, what the statistics are, how we could mitigate those risks, what are the chances of neonatal care requirements and things like that. All right, it's all taken in as part of a large package. Okay. So here we go. They're all a few bundled up here. So you can see this is the infographic style. There's a few of them dotted around. We've got them on prolonged pregnancy. There's about 15 topics at the moment, with more coming out on a monthly basis. We've got your BMI greater than 35 on there and your previous preeclampsia. These are the short pieces on your links here, so it'll take you to everything. We're not going to hide anything, we'll take you everywhere. They're really well appreciated, and they're sent via electronic email. They're sent when it's appropriate for that woman, okay? So at the very beginning of pregnancy, it's sometimes like a BMI or previous preeclampsia. You're going to know about that, so you can give that woman even more time. Prolonged pregnancy, okay, we don't send it to them at 42 weeks. We generally send them if they've had a discussion about it between 40 and 41 weeks to be able to make that discussion. We have other ones in there. Breech presentation is the latest one that we've released. Obviously, the woman is not going to need that until she's about 35, 36 weeks. We will give it to them before they have their scan to confirm it, so they've got time to think about their options. Time is all people are asking for. And these are the information sheets. As you can see, a little bit more wordy. Okay, they contain the evidence, they contain potential plans, they contain potential chances of things happening. We will sort through the evidence for them. So the maternal age one and breech presentation, there's a couple of well-known trials that are around those ones, which we will take apart but put back together again for the woman, and then provide them with the links for it as well. Again, these can go at any time. The one key one that we do have that goes to almost every single woman is what we call a home birth / home assessment one. One of our core standards of care is to provide home assessment for all our women in labour. So that is, we will go to their home, we will provide them with our time, our support, and we will assess them maternally, fetally, whether or not they need a vaginal examination, and we will then be able to contact the local acute trust if they're planning on birth in there to be able to ease that journey for them and to stop them toing and froing. So they will have that home assessment sheet regardless. It does lead on to home birth because women labour at different rates, and we could turn up and we think, well, she's probably about 5 centimetres, she's labouring well, established labour. When we get there, actually, you know, there's a head coming out and there's a baby about to be born. So we will pre-inform her that that home assessment could lead to a home birth, and if she's happy with that, all right. But everybody will get one of those. Okay, so quality assurance processes through it and how we sort of do it within this complex care. We start at the very beginning with booking. Midwives refer to the MMR, and they will see whether they need complex care planning. Now, whether that's with shared care, whether it's with specialists, or whether they're actually declining that shared care. They will start off with an initial risk assessment. Okay, so you're all used to risk assessments and things like that. Our midwives will write the risk assessment and the potential plan of care of what's going on. That's the first risk assessment they do. They will do 3 as a basic throughout their pregnancy. The next one comes between 28 and 36 weeks, and this is more to do with planning what's going to happen for birth. So what does the woman want? What is she thinking about? Does she need an individualised care plan? Have all the risks been mitigated? There's a wider gap for it because some risks aren't mitigated, and one of the main ones is growth scans. So if you're having serial growth scans all the way until birth, you can't really sort of preempt that size or whether it's within that normal range until at least you've had one around 36 weeks before you have your next one. At 12 weeks, we instigate what we call 4 weekly fresh eyes and exception reporting. This is an internal process, not necessarily, we've just changed it actually and taken it away from the midwives so they've got more time to spend with their women, and this will be sort of done by leads now. We're looking at their care, we're taking random samples, we're trying to see, are they on the right care plan? Do they need more support? Does that midwife need more support? Does that woman need more information? And the exception reporting is for those women who are not low risk, who would traditionally not be said to go and birth in an MLU or a home birth. Okay. 16 weeks is where we start our pregnancy centering and the personalised care plan review. This is done within our community hubs. So it's about bringing women together at the same gestation to try and form that community of women so they can support each other going forward. And that centering will hopefully continue all the way through to postnatal as well. Jump through to the 28 and 36 we've already discussed. At birth, even our complex care planning is not sort of put away or anything. Nothing ever goes perfect to plan. They have an immediate sort of assessment, so a home assessment. They will have an immediate risk assessment there to see if it goes. And the care plan, the individualised care plan, will be checked. We have what we call a timeout, so a 4-hour timeout, which all midwives adhere to. So they are looking then at maternal observations, everything going all right, comfort, fetal, baseline, everything going okay. And actually, we have a column for the midwives as well, okay? So that's check, are you hungry? Are you tired? Actually, is there a distraction? Is there something you're late for? Have you not rearranged something? And how long have you been there? Do you need help? Do you need support? And at any time, they can call them and go, actually, I'm done now. I'm really tired. I can't make these clinical decisions. Can somebody else come and swap in for me? And that happens all the time. It's a really, really good process. We have what we call ACEs. So ACEs is about having that clinical decision making in your team. All right, so you don't need to ring up that one person who knows everything to do it. It's about making those decisions. Midwives have the knowledge between them, okay? And sometimes you just need to take a step back from the clinical situation, go back to bases, use your HALT, use your individualised care plan, go back and look, okay, actually, is everything okay? Or do we need to do something else? All right. Escalation 24/7. As in all trust you, it's very easy when you're in trust because there's always staff there, 24/7 there's staff there. There's always a labour ward coordinator, an MLU manager, there's usually a matron hanging around somewhere. Obviously in the community aspect, that's very, very different. You don't have that person right next to you. So we have a 24 escalation, which is manned by the midwifery leads on a rolling basis. So immediately after your birth, you've got your postnatal sort of assessment, where we go and what do we need to do, including your neonatal and your maternal risks as well. And then we go through the postnatal period. Now we care for our women up to 4 to 6 weeks, depending on what they want. We actually care for quite a few women beyond 6 weeks as well, but that's the midwife's choice. We will have the communication then with the multidisciplinary teams again, for the discharge and the pro forma to the health visitor and the GP, to be able to say, yeah, actually everything's gone all right, this is what's happened in the postnatal period, or actually we needed to do certain things. Throughout this, should a woman be accessing shared care, our midwives will hopefully accompany that woman to the appointment to see the consultant or the registrar. This isn't to put our face anywhere. This is to actually support the woman, to advocate for that woman. All right. There is a lot, unfortunately, within complex care planning where there is no evidence. There is a lot of conditions where we don't actually know what's going to happen. So you can have various different opinions, and I'm sure in all of your trust you may have 8 to 10 consultants, but if you pick a certain topic, they'll all have a different opinion on it. That's not nobody's fault. There just isn't the evidence there. There's a lot of trials we can't do in maternity care because it's not ethically right. So we've just got to be able to advocate for that woman while she's there. And it's really, really important. Going back to the booking, we've already contacted the local acute trust. So we have pro formas to be able to say, we have this lady, we have this woman, these are her risks, this is her plan. Yes, she wants your input. No, she doesn't want your input. Or actually, she hasn't decided yet, which is absolutely fine. And again, should any of these risk factors change, whether they go down, whether they go up, green, red, amber, wherever they are, we can communicate via that pro forma to the local acute trust to say what's going on. All right. And we will also update the risk assessment. We say 3 is the minimum, but you'll often find there's multiple ones. Okay, so they'll be changed for certain things. So for high NT at 12 weeks, or even at 12 weeks twins, you know, that it changes the complex care planning. So the caseloading midwifery model, the personalised care plan will hopefully be coming to everybody now. So families now have access not only to the personalised care budget, but they should also have access to a personalised care plan to allow them to sort of plan their pregnancy, their birth, their outcomes, their wishes, their wants, and how they felt. An evaluation should be done of that at the same time. Continuity of care, again, nobody in maternity could not be aware of this right now and how the push forward is to it. Continuity of care needs to be that named midwife throughout. Various places are doing this in different ways. We have a buddy system, and then we have the wider team and mama support. So mamas are our equivalent of MSWs, all right? Midwives and mothers assistants, and they support us out in the community with breastfeeding, parent education. We're hoping to push them towards smoking cessation support as well. And it's really important to have that continuity of care. That is what improves the outcomes, whether that be psychologically, physically, for the baby or for mum. That is what improves the outcomes. And continuity of care sometimes gets lost as we have to meet that statistic. We have to get that 20%. But are you looking at the outcomes? Are you looking at those that actually, are we actually having an effect on that group of women we've chosen to give continuity of care to? Or should we be looking at the people that actually need it? Okay. Safer birth, so that's for us. We have the MMR, the exceptions, escalation, timeout, training compliance, of which we do very well on. Works very well with caseloading that you keep running, and they will add to their own training compliance. So it's up to them when to come to the training. They can work it around. We're not mandating you must have it this month, which is really, really good. And we have a safer birth policy to incorporate all of that as well. And then collaborative working, really, really important when you're out in the community and caseloading. You've got to have shared communication, pathways with local trusts, shared care for the high risk or the complex care. Multidisciplinary team meetings happen on a monthly basis. We have very, very strong governance, very, very strong positive, proactive pathways. We do have multidisciplinary training. It's different from what most people would call it, because our multidisciplinary training is actually sometimes held with paramedics, okay? Because they are our multidisciplinary. There is no point having multidisciplinary training with a neonatologist who's never going to be at a home birth. So you've got to look a little bit outside the box. And then we have a very strong positive safeguarding team as well. Okay, this is just brief what our midwives and our service users have said. And we take a lot of pride in what the service user says. We're very, very proud of it, but we will also take note when they didn't like something, when they want to make a change, okay? And that is one of our sort of forward feelings, is to get more involved with the service users to say, what did you want to change about our service, okay?